All right, so let's just keep that one in your head, and you're good for so many things. So, okay, so fluid and electrolytes, again, not a huge topic, and we'll come back to some of this stuff later. Especially, it comes back into play in emergency medicine and things like that, but we'll touch base on some of the things today. So fluids, I don't have a ton to say about fluid replacement. Fluid replacement is not always a science. Yes, there's mg per kilo dosing. So like, for example, if somebody comes in and they're septic, you give them 30 mil per kilo as the evidence-based regimen. Do you have to get all 30 mil per kilo in, exactly 2,432 mils? No, it doesn't matter if you do 2,000 or 2,500 probably, but some things have more strict guidelines for fluid replacement than others. So again, I'm not really going to talk about that. I'm not going to test you on that. What I do want to talk about are the different products, just so you know, and what you, as far as like what you see and what you have available to you to use. There's a lot of different maintenance fluid solutions out there, and we can combine things and make custom things too. So pretty much, if you want something, we can make it. Tonicity has a lot to do with it. So normal saline, 0.9% saline is going to be isotonic. Half normal saline obviously is not going to be. So for half normal, you can add, like, let's say you have a drug that's going into half normal. Like, what do we have in half normal right now? Heparin. Heparin drips are all in half normal saline. Heparin adds enough tonicity to the solution so that combining it with half normal saline makes it pretty isotonic. Problem is, if your tonicity gets too off, then you can get some phlebitis and infusion. We can work around that. If you're giving it in a central line, it probably doesn't matter a whole lot. It can also dilute electrolytes and things like that, but overall, it all depends on the volume. Like if you're giving somebody a lot of normal saline, that's not going to make their sodium change all that much, because their sodium should be about, it ends up being about 154 milliequivalents per liter. And you guys have talked about lab values, right? A little bit. Normal sodiums. It's a little high for sodium, but it's pretty much in the normal range for what we'd see a sodium at. Half normal, again, would dilute over time. So if you gave somebody liters and liters and liters of half normal, eventually their sodium is going to trickle down. We don't want that, but no one does that. If you're doing maintenance replacement, you're just almost all the time going to be giving normal saline. The only times we change things up a little bit for straight up fluid replacement are we might add a little bit of potassium to the bag. So like we have some pre-made cocktails that are like half normal, D5, and then they have varying amounts of potassium in there. So if somebody doesn't need a ton of potassium replacement, but they're kind of one of those people that's slowly losing potassium and you just can't keep the potassium up, switch their maintenance fluids over to something with K in it. That's a common one we use, especially for patients who are on insulin drips, continuous infusions. We're going to talk about insulin next semester. We'll talk about it a little bit today, but the idea is insulin drives potassium into cells. So anytime you give somebody insulin, for whatever reason, it's going to cause their K to drop a little bit. Most people, it doesn't cause a huge effect. So it's not like diabetics out there who are using insulin regularly have to take potassium replacement. But the point is if you have that, something like that, a situation where somebody is getting regular insulin and you do see their K slipping, that's a replacement fluid we can get. And we have those, again, we have cocktails like that pre-made coming with various amounts of K. But really, we can do anything. You'll see various combinations used. Most medications are going to be combined, for IV medications, are going to either be in saline or dextrose 5%. And you might see some other things here and there. Lactated ringers is used mostly for OB-related indications. Why they use lactated ringers, I'm not entirely sure. It's a good question, probably maybe worth research if you really care, but I'm assuming it was done a long time ago and somebody decided to do this and it stuck for whatever reason. It's kind of like a lot of OB, not to rag on OB, but they do things a little bit differently, and sometimes it's just because they've done it that way forever. They like the way it works. So like when we infuse oxytocin, for those of you who have experienced a birth or something like that, they give a big bag of oxytocin right after childbirth. It clamps down the uterus and prevents bleeding. That's always in lactated ringers. And they always use lactated ringers as a replacement solution for OB for whatever reason. Could you use normal saline? Absolutely. In fact, we had an issue where this was last year. If you guys remember the hurricane in Puerto Rico, it actually wiped out the majority of drug fluid production for Baxter, which is one of the biggest suppliers in the U.S. market. So actually, the weirdest thing is that we had all these drugs. Normally, we don't have drugs. Fluids have never been an issue. Sometimes we run out of drugs here and there. So they stop getting made or they go in shortage or whatever. We actually had fluid shortages. So we didn't have enough fluids to put the drugs into. So we had to switch things around. So we were going between lactated ringers, and we could get maybe a pallet of lactated ringers, and the next week we could get a pallet of normal saline. And you wouldn't even believe it. You couldn't even get sterile water from some of these sites. So it was ridiculous. But the point is, a lot of it's interchangeable. So don't think that you have to use one or the other in a certain situation. Sometimes drugs are only compatible in certain solutions. So we'll run into the situation where if somebody's getting, let's say they're on a lot of drips in an ICU, or maybe they're on a lot of IV medications and they're getting continuous piggyback infusions regularly throughout the day, and you're worried about their blood sugar. Let's say all those medications are in dextrose. Well, that can cause a little bit of sugar load over time. If the person's diabetic, that may be concerning. So as a provider, if you're worried about that, you can always ask your pharmacy team or whatever. And of course, we're talking about inpatient here. Outpatients doesn't really matter. But you can always ask if there's a way to put something in normal saline, because majority of the time stuff's going to be compatible in normal saline. It just depends on what we do. And in fact, due to some of these shortages, we actually switched a lot of our stuff to normal saline during that fluid shortage because we were running out of dextrose. And now all of our standard stuff is in normal saline. And I think it's just better for patient care because you don't really run into issues with normal saline. Nobody cares if you're giving too much normal saline because, again, it's isotonic. Your body's getting the same sodium. You aren't diluting anything out, really. Whereas with the dextrose, you can get some complications with that. Yeah.
So I guess I've heard the lactated ringers a million times, but where does that name come from, or like what's the difference between what's in lactated ringers versus normal?
I'll show you that on the next slide. I don't know where the name comes from. I don't know if there's a guy named Ringer who made it up, or if it, yeah. I'll show you the compositions here in a second. Let's just talk about colloids really quick. I think I mentioned colloids a while ago during some lecture, but albumins is probably the most common colloid. Remember, colloid is giving somebody volume, and it's going to keep volume fast. So like where we like albumin, if you have sudden blood loss, so if you work in any procedural areas, this is more of an anesthesia thing that they're probably going to be giving, but certainly if you are involved in the procedure, you might have to see this done where if somebody gets a sudden blood loss, commonly like an example would be like you're in electrophysiology lab, interventional cardiology, and a lead gets out, big massive blood loss suddenly. You have to get a lot of albumin in that person fast to hopefully keep the fluid centralized. And that's the idea there. You're just keeping the concentration gradient at status quo. Whereas if you just gave a whole bunch of normal saline, you're not really doing much. Hetastarch and dextrin are also used rarely. Where I don't know. I don't ever see these things ordered. We have some in the pharmacy. That's all I can tell you. And then blood and plasma products have some utility for obvious indications, right? So blood loss, we talked about FFP with respect to anticoagulation reversal. That's a common one there too, but that's situational depending on that. But that would be considered a fluid replacement. So if you're giving a bunch of units of packed red blood cells or frozen plasma, remember that is a substantial amount of fluid that comes along with that. So you are replacing fluids when you're doing that. It's just considered a colloidal fluid. It's not crystalline. Colloids are always going to be more money. Something like albumin, which is purified from humans, is going to cost more than salt water, right? So hopefully that's pretty apparent. And blood products, of course, going to be much more difficult. Not only there's restrictions to ordering and things like that, but just a more complicated process in general. So this shows you the differences in what's in these different products and the pHs relative to sweetness. So here's lactated ringers, and again, in case you're wondering what's in it. pH a little higher than normal saline. It's got some calcium, a very small amount of potassium and calcium. This is almost negligible. I mean, is this going to cause electrolyte changes in anyone? Probably not, but it's there. And then it's got lactate in it. So that's where the lactated name comes from. Again, the ringers, I'm not entirely sure where that is. The lactate is theoretically thought to increase the pH a little bit. So it's maybe a little bit more like physiologic pH. I mean, that's maybe somebody's argument. But again, we don't really use this. There was this, I think one of our intensivist groups got on a kick where they wanted to use lactated ringers as their replacement fluid for everything, and we talked them down from that. I don't know why. I don't know if it's more expensive. I'm guessing it is, but it's just, I don't think there's any evidence that says that it's really indicated in the situations and it has better outcomes than using normal saline. So everything else here should be pretty self-explanatory. Albumin comes in a couple different concentrations, comes as a concentrated form, which would be more you'd be more interested in using that maybe for like an albumin replacement, like somebody who's malnourished, whose albumin is low. If you're looking for a big bolus of volume that's got some albumin in it, then the 5% comes as a larger amount of fluid, so that might be useful for, like, again, those blood loss situations. That's what we use that for. but certainly other applications as well. So multiple options for fluid replacement. I'm not going to test you a ton on fluid replacement. I really just want you to know a little bit about the differences in colloidal and crystalloid, like combining those crystal products and colloidal products. And then you should be pretty straightforward. But I'm not going to give you a case or anything about fluid replacement. All right. So I'm going to work our way through the major electrolytes so we can talk about differences and disorders and basics for treatment. Sodium disorders are primarily related to hydration status. Signs and symptoms due to cell volume changes, so your concentration gradient is changing, fluids are shifting. Serum sodium levels can give insight into extracellular fluid issues. So we think of sodium as an extracellular cation, and that's going to give you, so like if your sodium's changing, it's your total hydration status. So contrary to potassium, is quite a bit different, so it's more of an intracellular cation. We'll talk about that later. Rapid shift in sodium and H2O can cause serious central nervous system damage. So, sodium disorder, especially hyponatremia, can cause really significant central nervous system symptoms, especially altered mental status. And we talked about that a little bit with thiazide diuretics. I think I mentioned that, but certainly something to be aware of here, and that would be the biggest complication with hyponatremia. So hyponatremia, by definition, is going to depend, and a lot of these definitions, I'm not going to test you on, first of all, the definitions of different hypo or hypers. A lot of that can have to do with different labs might have different criteria. So you might go to one hospital and they say their cutoff is 135, another hospital might say it's 130. They might say 150 is the upper end, another would say 155. Again, you get the point. It can vary slightly from place to place depending on how the lab runs their assay. Highest concern is going to be, and highest risk patients are going to be elderly and neonatal populations. And clinical concern really depends on a couple things. So how low? A patient with a sodium of 130 probably isn't going to be symptomatic. A patient with a sodium of 112 probably will be. Acute changes, how fast did this happen? Some people are chronically hyponatremic, so they might come in at like the 120s, but they seem fine. They might just have always been that way due to medication. Some medications waste sodium, and some conditions waste sodium more often. Presentation, again, depending on what you're going to do as far as how aggressively you're going to treat this is going to depend on how that patient looks when they come in. You're going to notice something's off right away because they'll be altered. People can present mildly with lethargy, muscle cramps, anorexia, nausea, vomiting, headache, very generic symptoms, right? That's not going to lead you to, oh yeah, that's hyponatremia. I mean, you would maybe associate that once you got the lab value, but right off the bat, that's not going to be anything. What would be a red flag is somebody who has psych side effects or is having an agitation or schizophrenic-like exacerbation who has no history of mental illness. That's a big red flag. And so that is, and again, I've actually seen this a couple times. It's interesting from a clinical perspective because it does happen. And those patients that I've seen it on have usually been in the low, like 110s, 110s, like 110 to 117-ish, like that area. So anyway, confusion, agitation, disorientation. Again, presenting like a mental health condition. Depressed reflexes, abnormal breathing, hypothermia, seizures, and coma can happen with advance. So essentially, you're causing central nervous system damage, and if you don't reverse it quickly and control environment, you can end up with permanent damage there. So it is a serious emergency that we want to address specifically, but the low-grade hyponatremia isn't, so that you could maybe replace orally. So it really, again, depends on how low it is, how fast it happened, and what the patient is presenting with. Okay, some causes you might see. If somebody gets a lot of D5 without any added saline, you can dilute serum sodium over time. So this is, again, rare. You usually aren't using dextrose 5% in massive quantities to replace fluids. You shouldn't be. There's no reason to do that. If we have somebody who's like hypoglycemic, for example, you might think, well, what if their blood sugar gets low? Would you ever do that? No, you usually use a more concentrated product that's less volume, so you aren't diluting things out, but you're still getting the sugar in. So we'll use like a dextrose 50%. That's for more severe instances. We can push that slowly. And we also have D10, so dextrose 10% infusions that we'll give for those types of patients for like a more mild case. But anyway, concentrated's better. Again, less dilution. If this does happen, if the person, again, is getting a lot of IV piggybacks and they all happen to be in dextrose, you can always switch them, try and switch things to normal saline. switch them to D5 half normal or D5 normal saline. All those should be appropriate, or hopefully you can find some sort of base solution that works for that patient. Hyperglycemia can cause an increase in serum osmolality, and then you get water to be pulled from the intracellular space into the extracellular space, and that causes dilution in extracellular sodium. Things can happen similarly with any other type of solute that you're infusing, like a mannitol infusion. We'll talk about mannitol during critical care a little bit more. Its biggest role, we talked about it briefly during glaucoma, but its biggest role is for brain bleeds, so it helps reduce swelling if somebody's bleeding, if it's having like an intracerebral hemorrhage or something like that. So serum sodium decreases by 1.7, that should be milliequivalents per 100 milligrams, deciliters blood glucose increase. So every 100 milligrams of blood glucose you get, so if your person's hyperglycemic, that's going to decrease their sodium. So if we really want to get their actual sodium, you can do a corrected calculation here that I've got here. It's their observed blood glucose minus 100 times their normal, divided by 100, and then times 1.7. That should be your expected sodium decrease, and then you can get the corrected sodium from that. So the point in talking about this is that people who are really hyperglycemic are going to have a sodium level that comes back. It's going to be probably abnormal, and that might not be actually what their sodium is. So we have to figure that out by the calculation. That'll give you a better picture. So it's not really cause for concern, again, unless they're symptomatic. All right, so that's going to cause, I mean, people are generally not getting really symptomatic, hyponatremic on D5 infusions and hyperglycemic episodes. You might see some transient decreases and some mild cases, but it's probably not going to be like the 110 CNS disturbance type thing. More serious causes, chronic dehydration, or significant, I should say, not chronic, significant diarrhea, dehydration, and diuretics. So hypovolemia is going to waste a lot of sodium, depending on what you're giving. So some diuretics waste sodium, and that's going to cause that effect to happen. Contrary to that, you could have somebody who is dehydrated without diuretics, and you can actually see an increase in sodium. So think about that it's concentrated if they're losing water but retaining salt. So this has to be dehydration due to a diuretic being on board. Diarrhea can also cause it too because they aren't absorbing anything, so you're not really getting any electrolyte replacement that way. So you're just kind of losing everything. CHF, so think about fluid volume dilution, so and nephrosis causing kidneys to not work functionally, so you have some, again, volume dilution that way because things are backing up. And so your sodium is basically diluted out at that point. That's hypervolemic. Isovolemic would have to do with maybe some cases of other, like acute renal failure. It's probably acute kidney injury is not going to cause somebody to get fluid overloaded immediately, but you can start to see some electrolyte disturbances fairly quickly. SIADH, which we'll talk about here, symptom of inappropriate antidiuretic hormone, and polydipsia can cause isovolemic adhesis. Again, it all comes back to that rate of decline and severity of the current disease states. If it is a really serious clinical picture, you want to consider sodium replacement aggressively, and we'll talk about that there for a second. So what do you do for non-critical? If a non-critical patient, usually just fluid restriction, especially if they're hypervolemic, and oral sodium should be enough to fix anything that's non-critical. If they're hypovolemic, just replace the fluids with normal saline. Remember, normal saline is 154 milliequivalents per liter of sodium. So if you give that enough to the person, their sodium is going to trend up slowly. And then any offending agents. So if they over-diurese themselves with, metolazone or something, that would be something to remove or to hold at least temporarily. All right, so critical, this is going to be a case where you can debate normal saline or hypertonic. Usually you aren't going to give somebody normal saline if they're critically hyponatremic. It's just not going to replace it fast enough to be of value. It's going to take too long to normalize. So hypertonic saline is what we use in a lot of these patients. So it's 513 milliequivalents per liter versus 154. This is a really high-risk medication, and you can kill somebody if you do this incorrectly. It causes osmotic demyelination, which will cause permanent central nervous system damage, if not death. So I don't mean to scare people from using this, but just if you're ever going to order this, make sure you're doing it correctly, and make sure you're doing it conservatively. I realize that sometimes you might be in a situation where somebody has central nervous system damage already because they're severely hyponatremic, but you don't want to contribute to that by slamming them with a bunch of hypertonic saline. and there's safe ways to do this. So usually the idea is to avoid exceeding an increase in serum sodium of 12 milliequivalents per liter in 24 hours. So how do we do that? Well, you start a hypertonic drip on somebody, start it at a normal rate. Usually I use 25 to 50 mils per hour on essentially every patient. That's pretty much going to show you, and I'll show you a calculator you can use if you want to use this in clinical practice. But the idea here is that you monitor really frequently. So you're getting checks like every half hour to start with, and then depending on how aggressive your rate is or how stable the patient is, you can move to like every hour, every 2 hours. But certainly if somebody's getting hypertonic, especially in that acute phase, I would never not check. Well, I would always check at least every 2 hours. Anything less than that, then you can stay really on top of it. And if you're checking that frequently, it's almost impossible to mess it up. As long as somebody's watching it, theoretically your nurse or your pharmacist or whoever you've alerted to this, they can monitor those labs, follow up, and make sure that every time that lab comes back that rate's getting adjusted or stopped. If somebody comes back and says, whoa, we've gone 10 milliequivalents per liter and it's only been 13, 14 hours, maybe you need to stop at that point or go down to normal saline drip or something like that. So just monitoring is really big with this. All right, so again, very high-risk medication. It's something that usually has a bunch of warning stickers all over. Not that you guys will probably ever see a bag of it, because that'll be more of a nursing function to hang and maintain it. It's also pretty hard on the vasculature. So we always get the question on, if you get somebody coming in, can you infuse this peripherally, or do you have to give it through a central line? Usually it's okay to do. The rule with that in general is that if something is recommended to give central line, you can probably give it peripherally for a little bit, but the odds of you causing phlebitis and pain or blowing your IV site are substantially higher. So get that central line in as soon as you can, but don't let it delay patient care. So give the patient the med they need, get your access as you can. This is a little calculator I've used in the past from my, globalrph.com. which is sort of a sketchy looking website, but it's actually legit. Okay, so here we have, let's just do general things. 70 kilo male, at 100 would be a really low sodium. Let's say they're at 110. Target sodium, so again, we want to go up for, I don't know, 12 milliequivalents. So let's say our target is 122, and I'll just leave that as is. Let's see what it says to you. So here it says infuse 3% at a rate of 40.9 milliliters per hour. So I actually use this in practice, and again, most people are going to come in around 25 to 50 mils per hour. I don't know if I've ever seen it infusing faster than 50. And again, I'm not going to test you on this, so I don't want you to know the rates, because it's something that you should probably look at if you get a patient like that. But it is something to think about as far as just how fast can you go and how aggressively do you need to go. And that's pretty much what it comes down to. What else do I want to say about this? Yeah, there's a lot of different calculators out there that you can look at as far as actually telling you how to do all the calculations, how to calculate sodium replacement. It's super complicated. I didn't know this existed, and I was maybe a year or two into practice in the ER, and I had a case come in, and one of the doctors asked me to figure out how much sodium to give, and I had no idea. I called our ICU pharmacist. He had no idea. So I go to UpToDate, and I'm looking at all the calculations, and I actually did it all by hand on this big piece of paper. And it was complicated. I mean, complicated, relatively speaking, like for hand math, right? Kind of complicated. And I got a rate that was, I don't know, I think it was like 40 or something like that. And so I was like, well, this sounds okay. And then I was talking to my colleague the next day who had worked several years more than me. She's like, oh, just go to Global RPH. And then I went and typed it in. Sure enough, it was a pretty similar number to what I had spent like an hour trying to calculate. And no, we didn't delay care for an hour. They were still kind of deciding what to do. So I did have some time to figure it all out. But it was a learning opportunity, right? So always use technology if you have the opportunity to do so. You don't have to always crank things out by hand. But good experience for me. Sure, why not? Oops. All right. Another thing a syndrome that piggybacks off of the hyponatremia concept is this SIADH. You can talk about SIADH in other classes. I mentioned it, so it's a familiar thing. Too much antidiuretic hormone. So drug-induced, this is a common thing for a couple different types of drugs. Desmopressin is basically antidiuretic hormone. So that can, of course, cause it if you're giving somebody too much antidiuretic hormone. or it's an analog and works the same way. Phenothiazines, which are kind of antipsychotic, antiemetic, and antihistaminic drugs. We haven't talked about many of them, but they are kind of common, especially like compazine, if you've heard of that, or prochlorperazine is a common antiemetic used. That's, for example, a phenothiazine. SSRIs, so selective serotonin reuptake inhibitors, the most common antidepressant class on the market, so Prozac, Zoloft, etc. Carbamazepine, which is a drug used for neuropathic pain, seizures, bipolar disorder. Cyclophosphamide, chemotherapy, and vincristine, so a couple of chemo drugs can cause this. So some more common medications, especially the SSRIs. So every time you prescribe an SSRI, which probably will happen some point in your career because they're so popular and common and relatively safe, this is one of the side effects they have. And some people are sensitive to it. I don't really see, I don't know if I've ever seen like an SSRI-induced case of severe hyponatremia, but it's certainly possible that they can get a transient case of hyponatremia from an SSRI. And it's because it's inducing antidiuretic hormone in an inappropriate way, and that's basically the roundabout mechanism. This is why they could cause hyponatremia. Treatment, fluid restrict the patient, increase sodium intake, consider hypertonic if severe. So you treat it just like you would like a diuretic induced or another type of class related case like that. Loop diuretics can help get rid of free water. Loop diuretics don't waste sodium, but they will waste fluid. So that's a way, if fluid restriction isn't going to be aggressive enough, you can loop some of the fluid off that way, diuresing it. Vasopressin receptor antagonists, or VRAs, would be the other option. VRAs, all I really want you to know about VRAs is that they're sort of the last line for hyponatremia. And that's really it. If you want to read more about them, you're welcome to. They're not super common. They're really expensive. And I feel like their efficacy over fluid restriction or diuresis is a little bit questionable. So they all end in Vaptan. So kind of like some of the common ones are Conivaptan or Tolvaptan. Their mechanism is that they promote free water loss via sodium loss, without sodium loss, via decreasing collecting permeability to free water. So they kind of have a diuretic-esque mechanism. They're working in the same area and similar results is what's going to happen as you would get to a loop diuretic. IV loading dose plus a 24-hour infusion is the common way to give this. Max duration of 4 days. Greater than that, and the drug isn't working. So if you aren't getting the results you need in 4 days, which would be kind of ridiculous, but possible, I suppose, you wouldn't want to keep using it. Risks, you can overly correct the sodium, so especially if you've got hypertonic infusing at the same time, which is, and again, this is where monitoring really helps out, to be watching that like a hawk and making sure those levels aren't getting too out of whack. Place in therapy, again, acute therapy only. This isn't a chronic thing you'd ever see a patient on. Really expensive, and I'm not totally sold on their use. Every once in a while we see it used. I think it does have some utility. If the patient isn't a diuretic candidate or isn't functioning with diuretic use, or they don't want to do hypertonic for whatever reason. So it does have some utility, but it's rare. So that's all I'll say about those. All right, hypernatremia. Dehydration, increased sodium intake, mineral corticoid use, and diabetes insipidus are all the causes of this. Severe dehydration is probably going to be not related to any diuretic interference, right? So it's not like you took too much thiazide diuretic this time. It's because you just were out in the desert for a week or something. You know, use your imagination. So you have somebody who's severely dehydrated, concentrated sodium, and they're hypernatremic. It's not common. I don't think I've ever seen somebody who's severely hypernatremic. Then again, I don't work in places where people hike in the desert and get lost. So that's what always comes back to my mind. It's the only way to get dehydrated. I know there's other ways, but suppose, okay, marathon runners, something like that. Okay, I'll stop. Anyway, less common. High serum sodium is indicative of cerebral cellular dehydration. So just like low sodium is bad for the brain, high sodium is also bad, right? So we just talked about this. Corrections in sodium aggressively can be bad too. So we really just want to make sure we're not getting into the extremes on our sodium, and when we're correcting, we're doing it gradually and effectively, but still effectively, I should say. Okay, so if somebody's volume down, we want to rehydrate to restore intravascular volume. That's really all that should be necessary to do. You can use normal saline. There's no reason why you couldn't give saline, because think about it, you're diluting it out, and you're going to dilute it down. If they were really high, you could consider like a half normal saline, or even some D5 potentially, if you were concerned about that. But you could theoretically use normal saline. There's no reason why you can't. It's not going to increase their sodium by giving them normal saline. If they're fluid overloaded, diuretics, loop diuretics should help with that. That would be really odd to see somebody fluid overloaded, but mineral corticoid use could potentially see that. It does affect how fluid and electrolytes are processed in the body, so you might see a fluid overloaded hypernatremic status on something like fludrocortisone if somebody's taking that regularly. If somebody has diabetes insipidus, you can decrease free water and consider desmopressants. We just talked about how desmopressants, synthetic ADH, and how it can actually cause the opposite effect if you give too much of it. Sure enough, it works for hypernatremia. So it comes orally and nasally, and you can use it in a variety of doses. Not, again, really common. Every once in a while, you see somebody on it chronically, because for some reason they're kind of chronically hypernatremic. Maybe it's usually because they have chronic diabetes insipidus of some kind, or they've had recurrent episodes of it. But again, not a really common presentation, and not something you're going to see a whole lot in your careers probably. Okay, potassium abnormalities. So sodium issues, problematic, but generally quite rare. It's not common. Potassium issues, very common. Especially in a lot of our chronic patients with multiple disease states. It's really a big deal in chronic kidney disease patients, so people with dialysis. If you miss a dialysis run, that's one of the most, that's probably the easiest way to go into cardiac arrest that I can think of. Miss your dialysis run, your potassium goes through the roof because you can't eliminate it, and then you have a ventricular arrhythmia because of it. So serum potassium levels can give insight into intracellular issues. Remember, more of an intracellular cation here. Responsible for protein and glycogen synthesis, resting membrane potential. And so really we're looking at heart issues when it comes to potassium. So that's the big thing. That's why this makes this so much more deadly. I always think of things that affect the central nervous system can cause major problems, right? You can cause brain damage, strokes, things like that. But at the end of the day, the person's body is still functioning. So there's some way maybe to get rehab or whatnot. With somebody's heart stops working, they're dead. There's no way we can come back from that. You put them on ECMO or give them a transplant or something like that, potentially, if you have access to those kind of resources. But if you're going to cardiac arrest because your potassium is sky high, there's not a whole lot you can do. You have a very small window of time to get that normalized, and that isn't always effective. I've been in countless codes where people are hyperkalemic, shoving the kitchen sink at them, and it's just too little too late at that point. It's very hard to get somebody back from a cardiac arrest, no matter what your resources are. Even at one of the best heart institutes in the world, it's still not possible all the time. So with that in mind, potassium abnormality is much more deadly than anything else we're going to talk about today. So it's more important, I think, to spend a little bit of time on it. Hypokalemia, so too low potassium isn't as concerning as too high of potassium. Somebody gets hypokalemic, usually asymptomatic until it gets really, really low. And it's hard for people to bottom out that much without somebody noticing. Loop diuretics would probably be a way to do it if you were going to cause it. That's probably one of the ones you'll see. So if you ever see somebody on a chronic regimen of furosemide, regardless of what the indication is, they're probably going to be on some potassium replacement as well, especially your heart failure patients. If their kidneys are working just fine, their kidneys are eliminating potassium as it comes in, the loops eliminating potassium as well. You're getting a synergistic effect there. So replacing potassium, daily potassium replacement, very common with chronic loop diuretic therapy. For a chronic kidney disease patient on loops, might be different. They might be on potassium replacement just because they might trend down over time if their kidneys are still functioning. A dialysis patient, probably not going to be on potassium because you're just adding potassium into a tank that has no exit, right? So you're filling it up. That's going to cause a lot of problems. So it just depends on where the patient is in their progression of kidney disease. But generally speaking, think about it this way. If your kidneys are functioning to a certain degree, even if you're looking at stage 3 or advanced stage, as long as the kidneys are functioning and they're on a loop diuretic, they're probably going to be on some kind of potassium replacement. And that's to prevent it from getting way too low. Again, we have a big buffer there, but and what am I talking about too low? Potassium ranges like 3.5 to 5.5, somewhere in there. And then if somebody gets down to like 2, maybe we get concerned. But even that, it's like, potassium is really easy to replace, which is one of the nice things about it. Sure, you can overdo it, but that's where, again, monitoring comes into play. Whenever we're replacing electrolytes, it's always important to be monitoring. And this goes for the outpatient world, too. If you're changing somebody, if you're working with a CKD patient and you up their potassium because they keep wasting it and they're on their loop diuretics for CKD symptoms or heart failure or whatever the patient might be, make sure they're getting back and following up quickly, so that you didn't accidentally increase their potassium too much, and all of a sudden they're hyperkalemic on the outpatient side of things. Okay, so again, not serious, really easy to correct. Hospitalized patients, alcoholic patients, patients on loop thiazide diuretic therapy. So besides the diuretic population that I just talked about, generally hospitalized patients tend to get low potassium. Is it because they're malnourished? Maybe just fluids diluting things out potentially too. Alcoholic patients are usually due to malnourishment. That's why you see low potassium with them. Presence of hypomagnesemia. So potassium can be, hypomag can be refractory to K replacement alone, and mag is a cofactor in potassium uptake. So the point is you can't replace potassium unless you're replacing the magnesium too. So a lot of times when you see somebody on replacement protocols, we usually use nursing-driven replacement protocols at our hospital. And so as a provider, you'd order a potassium replacement protocol, magnesium replacement protocol. Labs get drawn alongside your orders. Then the nurse would go in and look at those labs, click a couple buttons for some criteria. It spits out a calculator that says, okay, I want 80 milliequivalents of potassium split into 4 doses of 20 over the next 8 hours. I'm just making numbers up. And then that would get shot over to a pharmacist who would say, the nurse put this order in based on the protocol. I'm verifying it. It looks good. Everything's going to go through that way. So that's really how we do it in the inpatient side. It's not something you guys, fortunately, will have to get your hands dirty with, depending on the place you go to practice, I suppose. But it's a nice way for a lot of double checks into place. So that system is pretty fail-safe. And honestly, it's very hard. It'd be really hard to overdose somebody on a potassium replacement protocol. You can maybe slightly overdose them accidentally, but to give them enough to cause them to go into like a hyperkalemic crisis would be very hard to do on a replacement protocol. Basically, once you've done a few, you know that almost every patient's going to range. The max we really get would be like 120 milliequivalents in a day, which is a decent amount, but it's still spread way out. And somebody taking on the outpatient side might take oral potassium. They might be on like 40 milliequivalents a day. So really, it's not a huge range in the dose. What I will say about potassium too is that oral intake is very similar to, as far as absorption goes, it's almost 100% bioavailable. So if you can use the gut, oral is always just fine for potassium. They're really big pills. But it comes in packets, it comes in liquid, and ultimately you can give them IV if you wanted to as well. But the MAG protocol on top of that is really important too. So if you have both that are low, you have to replace both at the same time. We'll talk about MAG in a little more detail in a couple of slides here. All right, so I kind of got ahead of myself here, but the PO tablet brand names are Chlorcon or Kager, so you might hear that brand name used. Pretty common brand names. And again, they come as tablets, packets, and liquids. So a big tablet is never an excuse not to use oral. And in fact, these tablets are kind of an interesting design. They're like a pressed matrix of little tiny pellets. So you can put that tablet in liquid, and you don't want to crush it or smash it because that'll release all the potassium and then it'll absorb too quickly, because they are these little tiny pellets that are designed to be extended release. And so you can dissolve it into some sort of water, and it breaks down the matrix in between those pellets, and you can swallow it, but it retains the extended release mechanism on the drug. So therefore, you can take the pills, if your patient's having a hard time swallowing them, tell them to put it in some liquid, water, juice, whatever it might be, and swallow it that way. As long as they aren't like physically crushing it with something, that's the big thing not to do. And that retains, again, the extended release mechanism. If you crush it, that person's potassium is going to go up much faster than it would if it was extended releasing throughout the GI tract. And it's probably not going to cause a huge deal of potassium increase, but it could be enough to maybe spike them temporarily and cause some temporary problems. But anyway, usually replaced again. I talked about the hospital protocol, nursing and pharmacy monitored. And again, serum K follow-up monitoring. It's just as essential for this, if not more so, than with sodium. So anytime you're messing with somebody's electrolytes, you always need to be checking it pretty regularly. So like our protocol has it built in when the nurse orders whatever replacement it is, it'll tell them to put in a lab checkup after 4 hours after the last infusion or whatever it is. So it has a recommendation there too. So it's all, again, a nice little package that's designed to be friendly for providers, nursing driven, so it gives them some latitude and care, pharmacy double check, and then labs are done to make sure that things are going okay. Any questions on K replacement? IV potassium, if you give a lot of it, has some issues with vascular access, so it can burn when it's infused. So concentrated potassium can only be given really in a central line, or should only be given in a central line. So actually, sometimes it's easier to give oral replacement than it is, because like our potassium IV bags come as 10 milliequivalents and 20, and our tablets you can give like 40 milliequivalents at a time. So you can actually dose higher orally and give a better sustained response. Again, I'm just advocating for the GI tract here. If somebody's gut is working fine, go with oral. It's going to be easier on the veins, less nursing work. If you want to replace 80 milliequivalents IV and they're peripheral aligned, that nurse has to do 8 bags of 10 milliequivalents potassium. What's 8? That not 5. 8 different bags of potassium every hour they're replacing that. So it's a lot of nursing work. And sure, it's relevant in some situations. So not to dissuade you from ordering it, but just think about that. If you're just thinking, oh, IV is easier, they've got a line. Well, it's going to tie up that line for 8 hours. Okay, hyper-K. So this is usually serum potassium over 5, over 5.5, depending on, again, what your labs are saying. More dangerous than hyponatremia, medical emergency, and renal failure patients. It's a big thing with them. Big things here to watch for are EKG changes. So somebody with hyperkalemia who comes in with a wide QRS complex and peak T waves, that's a major red flag. That means that that person is pretty close to having a cardiac arrest, or at least a major cardiac event if we don't correct that quickly. Treatment based primarily around driving potassium into the cells or removing the potassium. So if you have somebody who comes in, dialysis patient, missed dialysis, their potassium 7.5, and their EKG looks great, and you can get them to emergent dialysis, do that. That's great. That'll take care of the problem, and you don't really have to worry about it. If they're starting to have EKG changes, that's when you want to start to aggressively manage them. You still want to get them to dialysis eventually, but you can start to do some things beforehand. And this is where we do our hyperkalemia treatment. So I do want you to know this for this exam. I want you to know essentially where things fit into place. It's borderlining on emergency medicine a little bit, but it's hard to talk about it without talking about the emergent part of it. So here we go anyway. So step 1, if somebody is having EKG changes, the first thing you always want to do is give them calcium. Calcium stabilizes the cardiac membrane, and you can do 2 different types of calcium replacement. Chloride or gluconate. Chloride's faster acting and it's more bioavailable, and I'll say that again in another slide. Gluconate is a little bit slower onset. So for a more mild case, maybe they just come in and their T waves are looking kind of peaked, and you're like, give them a little bit of calcium gluconate. It's not going to hurt them. Calcium chloride's really hard on the veins, and so that's more of a, like, this person's having a cardiac arrest, give them calcium chloride. Or we're out of calcium gluconate because it's a drug shortage item, so we have to give calcium chloride, something like that. But gluconate's a preferred option if you have a more mild case. Okay, let's say they're in and they don't have, either they had EKG changes and you gave them calcium already, or they didn't have any EKG changes. If it's still urgent enough where it's like their potassium is really high and we can't get them to dialysis, or it's just high for another reason, this is what you're going to do. It's all around insulin. Insulin is a primary agent. We give a pretty high dose of insulin. We give 10 units of regular insulin IV push, which is a pretty decent dose, especially for a non-diabetic patient or an insulin-naive patient. And that will cause potassium to get driven back into the cells. Insulin stimulates the sodium-potassium ATPase through a kind of a really weird roundabout mechanism. But it basically helps with cardiac myocyte metabolism, which is why it's going to cause sodium-potassium ATPase upregulation on those different cells. So potassium is getting sucked back into the cells, and that's going to be the best option to do that quickly. So the important thing here is calcium doesn't do anything to your potassium level. It doesn't change how much potassium you have circulating in your blood. What it does do is, again, it stabilizes the cardiac membrane, prevents you from going into arrhythmia, or it helps you while you're in arrhythmia, maybe from going into like an asystole. Insulin is the key here to driving it into the cells. You would give dextrose first, like let's say your patient comes in, let's use a CKD patient again because that's the module we're on. So we got a CKD patient, they're coming in, they missed dialysis, their potassium 7.5, they had EKG changes, you gave them an amp of calcium. Now what do? You check a blood glucose level because you don't want to cause hypoglycemia. Hypoglycemia causes seizures and coma and all sorts of nasty things. And 10 units of regular insulin IV push will cause some hypoglycemia in patients. So what we need to do first, check their blood sugar. they might be diabetic too, and their blood sugar might be 350, and in that case, who cares? Insulin's probably great for them. If their blood sugar is 70 or 100, or like normal patient, then you got to give dextrose first. So we give a concentrated amp of dextrose, follow that up with our insulin immediately, and then we have some optional items. These are less effective than insulin at getting potassium back in the cells, but sodium bicarbonate and albuterol nebulization solution can be used, and those have some similar mechanisms to insulin. They all have some ATPase stimulating properties. They aren't quite as effective, but usually once the patient's gotten the primary treatments, we'll start giving the other things. An amp of sodium bicarb is not going to really hurt anyone, and albuterol neb certainly won't be a problem for most patients to tolerate. So for that, they're pretty benign treatments. And other than that, assuming the patient's doing okay at this point, we just want to keep following up with the potassium. We want to follow up with their blood sugar too to make sure that's not getting too low, and redose dextrose if we have to. Lasix. Lasix is a good option for less severe cases. So this is somebody who comes in who has working kidneys, first of all, right? If somebody's on dialysis, giving them Lasix isn't going to do anything. So remember that little caveat detail there. Somebody comes in with hyperkalemia, Lasix is a good option for non-immediate potassium wasting. So it's going to have some sustained effects too. So after you did all this and they have functioning kidneys, you could consider some Lasix to keep the potassium going, keep the potassium wasting happening. But how long does Lasix take to work? I don't remember. When you start seeing diuresis? Yeah, like 30 minutes or an hour or something like that, even if you give it IV bolus. So again, in a really acute scenario, that's way too much time. So that's not going to be a good option for us right away. It's a logical choice because Lasix and loop diuretics absolutely waste potassium, but just think about it as a further down the line. Or again, that person who comes in, who's at 7 potassium, they're fine. Everything looks great. Give them some Lasix, let them sit in the ED, and let it kind of waste itself away. Or put them into OBS or something like that. Final step, or possibly a step for somebody whose potassium is just borderline high and you want to get rid of some, is sodium polystyrene, or Kxalate, or Kyanex, or two brand names of that. It's an oral GI active agent that exchanges potassium for sodium. So it pulls potassium out of the body and puts sodium into it via the GI different types of pumps that it interacts with. It takes about 24 hours to see effects, and it's really the last option you should give in an acute situation. But again, if you have a really non-acute situation and you don't even think it warrants loop diuretic therapy, you could give it to somebody for a mild case. One thing that sometimes nurses will ask me is they'll come, I think this is on some order sets for hyperkalemia. So if you're working in a hospital and you have a hyperkalemic patient and you use the order set, you guys know what order sets are? Has anybody ever mentioned this before? So order set is usually something in a hospital that's designed to make your life a lot easier. So when you have a hyperkalemic patient, instead of typing in all these medications separately, you type in hyperkalemia. It gives you all the medications, it gives you all the labs, it gives you all the monitoring, it sends nursing communications, does a lot of things for you. And you can go through and make little tweaks and stuff to it, but really it sends it all across. So like when I'm doing this, I use an order set because who wants to type everything in? But Kxalate is often on those order sets, and sometimes it doesn't get checked off, or it gets on there, and it's fine to give it, but what bugs me is when a nurse comes in and be like, can you verify the Kxalate or get it out because I need to give it? It's like, this person's acutely hyperkalemic, you know, they have EKG changes. That's the last thing that should be on your mind. So I just want to make that really clear, is that Kxalate is not the first thing you should think about when you think about hyperkalemia, especially in the acute phase. Again, for a really mild case, sure, but just remember it's going to take about a full day to really see the effects of it. All right, just talking about calcium really quick, chloride versus gluconate, since we're on the subject. Again, chloride is about 3 times the elemental of bioavailability. It's instantly bioavailable. It ionizes basically as soon as you give it, and it's very hard on peripheral vasculature. So it can be difficult to give if you don't have central access. That's another story. Gluconate, less elemental calcium, and slower bioavailability, but it's much easier on the blood vessels. So if you have an emergency cardiac arrest, definitely chloride, always chloride. If it's urgent and time is sensitive, but you have time to have your IV room, maybe make up a bag of it so you can infuse it slowly, gluconate is going to be a good drug for that. All right, any questions on potassium? I feel like this always trips people up a little bit. So I would go over it because there will be some test questions on it. You're like, that's obvious.
So you would never, correct me if I'm wrong in the understanding, because dextrose is like sugar and insulin's insulin, so you never give both of them. It's kind of like an either or.
Nope,
So
you would give both of them.
Okay.
Yep. So the dextrose is to prevent the insulin from bottom, because insulin is going to lower blood sugar in addition to getting your potassium into the cells. So it does both. It's just the blood sugar lowering effects are a side consequence of what we're trying to do here. We don't really want the blood sugar lowering effects, but that's what insulin does. So the dextrose is to prevent that from getting too low in a normal glycemic patient or a euglycemic patient.
One, they're on an extreme edge.
Right, if they're really hyperglycemic coming in. Yep, then you could get away without it. And even then, I know we haven't talked about this, getting into the weeds a little bit, but hyperglycemia, really hyperglycemic patients, unless they're super hyperglycemic, if somebody's like mildly hyperglycemic, a little bit of extra dextrose is not going to hurt them. So in the acute phase, not going to be a big deal. So I'd always err on the side of giving the dextrose if you're concerned about that. Yep.
I was just going to ask, if you're in an emergency situation and you don't have time to get a blood glucose, or you're just going to get both?
You do always have time to get a blood glucose because you have finger stick glucometers, so you should always do that. Yep. It's really fast. In an emergency situation, you've either got, and oftentimes they do it in the ambulance on the way over too. So if you're waiting for them, or your nurse should be able to do that in like seconds. It's really fast. And in the ED, we have you guys talked about labs at all? Like iStat, is that a term that's ever come up? So like in EDs and urgent cares, there's these little machines that they can have that aren't quite as accurate as a full blood draw done at an actual full laboratory, but they can run it on a cassette and do like a Chem 8 and basic, like an INR, things like that. And they can get those back to you really quickly. So you can actually get turnarounds on potassium and things like that in minutes that way. So that helps you at least get a picture of what's going on. So you can get labs really quickly. It's a good question to think about, like how do I get that information? And make sure your nurse is doing that. I mean, most ER nurses are going to be checking that. It's like one of the EM 101 things, like always check a sugar because it's so easy, cheap to do, and fast, and it can diagnose a lot of problems or rule out a lot of problems if you check the sugar right away. All right, magnesium abnormalities, very unusual to see really any side effects or complications from abnormal mag. Mag has a lot of interesting roles. It's a molecular stabilizer with RNA, DNA, and ribosomal proteins and things like that. Natural calcium channel blocker. It has antihypertensive properties and vasodilation. It's smooth muscle relaxation. Neurosynaptic transmission. It affects the release of acetylcholine, so it does have some CNS effects as well. It's ubiquitous in diet. It's your daily requirements are much lower than likely anyone's, or much lower. Well, the daily intake you're going to have is probably much higher than what your requirements is going to be if you're eating a fairly standard diet. Renal homeostasis, about 95% of filtered magnesium is reabsorbed, so your body doesn't waste a whole lot unless you're taking a loop diuretic of some kind. Hypomagnesium, or hypomagnesemia, I should say, usually occurs in hospitalized patients. That's probably going to be the most common population. A side funny story, my father-in-law kind of gets on these weird health kicks, and he was talking to me about taking special formulated magnesium and how, like, he read a study, or it's probably an article trying to sell him the magnesium, but I won't tell him that, although this is being recorded. Fortunately, he doesn't listen to my lectures. But he was telling me that everyone, like 80% of the population is hypomag. That's just crazy. That's not true. Hopefully if we checked all of us, we'd be fine. People who misinterpret certain studies say that actually high percentages of hospitalized patients tend to be hypomagnesemia. That is true. Generally, people walking around who are healthy should be normal magnesium. We'll just leave that at that. So I don't think everyone out there needs to be popping mag supplements. But anyway, side note ended here. So you have a hospitalized group of patients, much more common and critically ill. People who are also hypokalemic and people who are alcoholic patients are going to have higher risk factors associated with more aggressive treatment needs, probably. Usually associated with GI and renal disorders, decreased intestinal absorption, intestinal losses, renal wasting is going to cause wasting of magnesium. Drug causes diuretics, aminoglycosides, some chemotherapies like platinum agents, cisplatin, a couple other things can cause it, diuretics being probably the most common one on that list. Laxatives. It's kind of interesting because magnesium orally itself is a laxative. So if you try and replace it and somebody's already having issues with diarrhea, it's not going to be effective at all. So keep that in mind as we talk about the products here in a second. Symptoms: CV, neuromuscular, potentially muscle cramps, nausea, vomiting, and lethargy are the common ones people see with low magnesium. In really severe cases, you could see some more aggressive neurologic symptoms, but again, it's quite rare to actually have that bad of a low mag that you're going to see that. So, and magnesium side effects are quite rare. Usually, we're replacing it because we need to replace the potassium too, and that's why we're doing it. Okay, so we're going to resolve symptoms. If they are symptomatic, we want to resolve them. Get the mag to whatever your lab says is good. Usually like 1.8 to 2.2 is the magnesium range we're looking at. Correct that potassium as well. See if you can identify the underlying cause. Is it diuretic, where they have a week of gastroenteritis? That's possible to waste all your electrolytes or something like that. Oral options, over-the-counter products. Magnesium oxide is probably the most common and cheap one available. Comes 400 milligrams. People take it 1 to sometimes even 3 times a day. Magnesium chloride is a slow mag brand. You might see this. It's a more delayed release. People say it might have less GI-related side effects with that, but dosing is really limited by diarrhea. And some people will say, hey, we need to replace your magnesium, but like even our magnesium replacement protocol, if you're using oral in the hospital, it'll have you dose it, and it'll say if you get a loose stool, hold it for a certain amount of time. So sometimes that dosing strategy is you dose it until you start having diarrhea, which is great for the patients, right? Where potassium, if we flip back to potassium for a second, where potassium oral is a really great option with minimal side effects and good bioavailability, IV is kind of tricky to use with potassium. It's the opposite for mag. IV is preferred in a lot of cases. And if you think about a lot of the reasons why people might have low magnesium, let's take diuretics out of the equation, but if we look at like GI and GI disorders and distress, that's going to be a big cause of magnesium wasting, and oral options are not going to be something we can use for those specific patients. So IV is going to be preferred. So that's where we use magnesium sulfate. You can give 1 to 2 grams a time. We have a policy that says you have to infuse 1 gram over an hour. You can give magnesium a lot faster than that. We use it for some acute conditions. Like I mentioned it for asthma exacerbation, we infuse it over like 20 minutes for that. So it's safe to give it faster, but we just give it slowly because you don't really need to replace it quickly for a hypomagnesiemic patient unless the person was like really, really low and altered mental status or something like that. You could consider more aggressive. But I get this question from my providers a lot. Be like, I want to replace them. I want to give them 2 grams of mag, but I don't want them to sit in the ED for 2 more hours. Can I give it over an hour? Sure, go for it. No real problem with that. Easier if already IV access. If somebody has IV access, it's not going to cause GI issues with the IV magnesium. That's the biggest thing. So severe cases and avoiding those GI cases. So think about your patients who might have chemotherapy, induced nausea, vomiting, and be hypomag because of that. Gastroenteritis cases, anything. Basically, if you're considering oral, you want to make sure that patient doesn't have any other GI issues going on. If they don't have any GI issues and everything seems good, yeah, you could try some oral, but it depends on how severe the mag level is too, or how severely low it is, I should say. All right, hypermagnesemia, really uncommon, usually acute kidney injury or CKD plus excessive intake on top of that. So this would be like if my father-in-law who takes weird mag supplements got acute kidney injury and wasn't eliminating it. That's the patient you might see with this, but it's very unusual. Or somebody who skips dialysis. That's the other person who you might see more commonly probably than somebody who overdosed on supplements. Severe CV or neuromuscular complications in rare cases. Treatment, adequate renal function. Then you're going to do fluids and loop diuretics. Elemental calcium can cause some physiologic antagonism of magnesium's effects. So remember, think about calcium as a contractile ion. Magnesium relaxes, so it can kind of have some alternate effects. Not really going to help with the actual high mag. It's not going to cause mag to drop, but it might counteract the effects of maybe hypotension and some of those hemodynamic instabilities you might see with really high magnesium levels. Supportive care, pacing. Somebody could get symptomatically bradycardic if they have too high of magnesium, so you could pace them electrically out of it. vasopressors potentially to give peripheral vascular support, and even ventilation if they really need it. Again, I don't know if I've ever seen a MAG case that severe, but it's certainly possible. All right, so those are the major electrolytes. We're going to talk a ton about calcium next early in January. I think it's one of the first modules, or maybe the second module is bone mineral density. So we're going to come back to some of these topics and reinforce some of those concepts. But so I didn't talk about calcium. I did think I had a few slides on calcium on the previous renal lecture, so I can touch base on some of that. But I thought I'd see if there's any questions on the content first, and we can go from there, and then maybe I can just run through some of the renal stuff and do a quick review. Yes?
On one of the lectures, I think you ended up changing the slides during it, so I just wanted to confirm. One of the diuretics is more prone to cause kidney stones, and one of the diuretics is more of like a preventative, and I think, if I'm remembering right, it was loops are preventative and thiazides potentially cause?
Opposite.
Well, I'm asking.
Yes. Yes. Thiazides can be, I don't know if people actually take thiazides for kidney stone prevention or how common that is, but theoretically you could use it for that reason.
So thiazides prevent and loops cause?
Yes. Unless I'm getting a lot of confused stares. Am I confusing myself?
I think that's what it said originally. I think I switched it, but I'm going to do it.
Because I don't think anyone would ever take a loop diuretic for anything preventative. So I think what's coming into my head is that thiazides, and again, I don't think it's commonly done even.
So under loops here, you have...
That was the one who changed halfway though. So
Yeah.
Well, it said originally kidney stone risk, and then you changed it to treatment.